Thank you. Good morning, everyone. I am Amber Freeman. I am the Director of Training, Technical Assistance, and Community Impact at the Connecticut Coalition to End Homelessness. So thank you for joining us for our older adults, homelessness, mental health supports, and services training. We have seen an increase of older adults entering our homeless response system. And we've also seen that increase of older adults with mental health conditions. So this training today is just to go over some of the different things that we're seeing, as well as to touch on some of the services and supports available for them. We do have Erin Leavitt-Smith, who is the Director of Long-Term Services and Supports with the Statewide Services Division of DEMIS. So at this point, I'm going to hand it over to you, Erin, to start us off with your training. You are able to share your screen.
So just as Amber mentioned, I'm Erin Leavitt-Smith. I'm the Director of Long-Term Services and Supports. I've been with DEMIS 35 years. So I've done a lot of different things, did community mental health in Hartford for many years, worked in forensic services. So I oversaw bunch of criminal justice programs, and now I'm in statewide services. So I've kind of worked, the continuum with DEMIS over the years. So I don't know if those of you were at the conference last month at the convention center. So some of this might be a bit redundant, but really. We talked about kind of condensing and adding some things for this presentation. So and I ask if people have questions, please ask as we're going along. I don't know if someone can monitor if people have questions, and then just let me know since I can't really see people. But quick facts on older adults. There's over 40 million people, older adults living in the U.S. This number is only going to rise in the next 20 or 30 years. And it was interesting when I was in California, I bumped into a gentleman hiking, and it was Ojai, California, near Santa Barbara. And he said that their town there is aging, and that it was interesting. They built a high school for 1,800 to 2,000 students, and there's only 800 students in the high school right now, and they're having to redistrict. And part of the issue is he used the word, we're a graying town, and getting grayer, by the year. And so this is a national phenomenon, but Connecticut for sure is the 5th oldest state in the country, and we are rapidly growing old. So that's going to put a big burden on our services and how we look at healthcare in general. So by 2050, that number is going to more than double. We're going to have close to 89 million older adults. That's a huge number. Increasing in diversity. Most of those people live in the community, and almost a third are living alone. So 95% of older adults are in institutions, nursing homes or otherwise. It's estimated that upwards of 20 to 25% of older adults experience some mental health or substance use issue. And older adult women are more likely to have a mental health disorder, while men are more likely to have a substance use disorder. Now, this could also be due to the fact that men are less apt to report mental health issues, but still, when they look at statistics, women are more likely to have a mental health disorder or an identified mental health disorder. Next slide, please. So by 2050, with the homelessness, it's predicted that homelessness among people 65 or older will more than double. So in 2010, there were about 44. Now they're predicting in the next 20 plus years that that's that's going to more than double to 93,000 homeless seniors. And when we're talking seniors, again, we are, for this purpose, 65 and older. In the DMS world, older adults starts at 55, but for most statistics, older adults start at 65. More adults are aging into poverty. Oops, I'm sorry. Can we go back? So they're aging into poverty or homelessness due to economic factors. So Social Security staying flat. I know they had a big increase last year, but that not raise, you know, the cost of that increasing isn't matching inflation. Rental costs are going through the roof. So they're on a fixed income, but everything else around them is going up. So this is causing huge hardships for older adult population. And that's a staggering statistic that 45% of people were considered economically vulnerable. Next slide, please. So reasons for homelessness: lack of affordable housing. I'm sure you see that in your work in the homeless programs that you're involved in. I know we see it with our mental health clients on our mental health waiver and other programs that rents are going up at a huge rate, $300-400 a month sometimes. And again, if people are on a fixed income, that's going to be near impossible for someone to manage, or most of their money is going to be going to rent, which would leave them with less money for food, incidentals, so forth. So that's we're seeing that as a huge barrier across the board. Healthcare, the rising cost of healthcare. If they're on Medicaid and Medicare, most of their costs will probably be covered, but if they don't have Medicaid and they're on Medicare and they don't have good supplemental insurance or they can't afford it, you know, they could incur medical costs that they can't afford. And very often that does not include dental services. I mentioned the stagnant wages. You know, if they're not getting raises in their Social Security or pensions, you know, making it difficult to save any money or squeak by. All right, next slide, please. So who is an older adult? I guess it depends on your perspective. Is it a number? But aging happens over a lifespan. Technically, we're aging as soon as we're born. Some people, you know, they have that idea that we're always getting older. The physiological functioning does not necessarily correlate with the chronological age. And certainly you see a lot of people with severe and persistent mental illness or mental illness. And there are statistics that show that people with a severe and persistent mental illness have a lifespan 25 years shorter than that of the regular population. That's huge, huge difference. So with our SMI population, the aging process starts sooner. And we think that's probably due to the number and the medications, the heavy duty medications that they're on for many, many, many years. The fact that they might not have good access to good health care, that they don't necessarily have good access to healthy foods. They might not have the ability due to their mental illness to take care of themselves or take care of their needs as other people might. And so that all factors into that shorter lifespan. So we have three groups of older adults: the young older adult, the middle-aged, and the oldest. People are living longer and longer, and so people are living well into their 90s, and so that oldest group, 85 and older, is increasing, and it really is the fastest growing group. As the baby boomers age, that is going to be the fastest growing group of older adults. All right, next slide, please. So prevalence of mental illness. So upwards of 25% of older adults have some kind of psychiatric or mental health disorder. The most common are anxiety, depression, and dementia. Those are the most common with the older adult population. We do have people that have bipolar disorder and schizophrenia, but that's a smaller portion of the older adults and what we see in mental health. And certainly we see a really large prevalence of this in primary care settings, such as nursing homes and hospitals, and certainly the emergency departments. Next slide, please. So what is a mental illness? When we look at mental illness, we look at categories, and one is a thought disorder, a mood disorder or emotion, and a behavioral disorder, what we call our personality disorders. So those are typically how we kind of phrase this. We also have developmental disorders, which would be your DDS, autism, those kinds. But for us, when we're talking mental illness, we're talking thought, mood, or behavioral disorder. All of the disorders influence thoughts, moods, choices that people make. It affects all areas of functioning, social functioning, vocational functioning, and really impacts major life activities across the board. How it affects someone is unique to that individual. So somebody with schizophrenia standing next to another person with schizophrenia could look quite different in their level of functioning. It really depends on the severity of the illness and response to treatment. So again, upwards of 20 to 25% of people 55 and older will experience some kind of mental health crisis or concern. So what they have in common, what all of the thought, mood, and behavioral disorders have in common is a decreased predictability. They have a decreased ability to problem solve, so that becomes more of a challenge for people, especially if they're in the throes of a psychotic episode or a manic or a depressive episode. And their flexibility becomes more rigid. So you might see more rigid thinking or rigidity in the way they want to do things or handle their life. What we will see is an increase in anxiety. So someone who may not necessarily have an anxiety disorder, but has mania or schizophrenia or dementia, we can see that anxiety very often is tied to those disorders as well. So we'll see an increase in anxiety, fear, and suspiciousness. So very often when people get psychotic, for instance, they get more fearful, they're more paranoid, they get suspicious of people. It's all part of their mental illness and their thought process. Next slide, please. So the more common forms of mental illness that we see in the older adult population are what we call the 3Ds. Anxiety is very common, but the 3Ds are the most prevalent, and that's depression, dementia, and delirium. So dementia is a cognitive process. It's a degenerative cognitive process that happens over a period of time. Delirium is a medical condition that is treatable, and if treated, will subside. So we want to get that treated early. All right, next slide, please. And we'll go into now a little more about, oh, well, I guess I didn't do that. Hold on a second. I'm sorry. Okay. All right. I'm just saying. So going back to that, so let me just explain dementia, because I took out those slides. So dementia, again, is a degenerative cognitive disorder. So what we see is a decrease in one's functional and cognitive ability over a period of time. It is not treatable. There are treatments that can help slow the progression, but it doesn't stop the progression. And what we see is an overall decrease in every area of functioning, to the point where someone will need total care, most likely, at the end of their life cycle. So Very often people with dementia will have symptoms that could mimic someone with a psychotic disorder. But what we're looking at with dementia is signs of forgetfulness, not really understanding, a decrease in comprehension, that kind of thing. And when we start to see that, it should be kind of a red flag that maybe there's a cognitive decline going on. With dementia, with delirium, it is a medical condition. And again, when someone presents with delirium, they can present and look like they have a psychotic thought process going on. With delirium, though, it can be treated, and the signs of delirium come on very quickly, very opposite of that of dementia. So if you talk to someone in the morning and they look to be themselves, and they come back in the afternoon and they're looking confused and they don't know what's going on, and they might be not making sense when they're talking, that's not a dementing process. It could be a red flag that there's something medical going on, and so someone should go and get checked out because it is treatable. If it's treated early, it subsides, fairly quickly. If it's not treated, it could ultimately result in death if not treated. Now, that's not going to happen within 24 or 48 hours, but it could long term if people are misdiagnosed and not treated. Sometimes delirium comes on because of medications. A very common cause of delirium is a UTI. So if people have a urinary tract infection and that's not being treated, that can throw someone into a delirious state. So we want to be sure that it's diagnosed, the delirium, and then the cause, so that the cause can be treated as well. So quick onset for delirium, slow onset for dementia. So to successfully work with older adults, we need to understand the relationship between the physical and the mental health. So how does stress lead to their problems? And what I see with older adults, and I see it within myself, is that as people age, they have less ability to, how do I want to say this? I have less patience, I guess, or I get riled more easily. If a problem presents itself, it's, you're getting anxious right away rather than kind of taking a breath and saying, okay, maybe we can work through this. And so we see that as problems arise, they become bigger and bigger and become more overwhelming. Physical problems. So as people age and they become physically, I don't want to say disabled, but they begin to have physical limitations and physical issues. That often can lead to some depressive symptoms, and understanding that loss of that physical ability and the changes that they can't do what they used to do, it can be really problematic. And I know I can't do what I used to do when I was 30, and I have to remind myself I'm no longer 30, So that's really difficult as people age. And of course, everyone's own interpersonal character profile, how were they growing up? Were they resilient or not resilient? If you're not resilient younger, you're probably not going to be resilient as an older adult. And certainly the social and psychological resources, what we've just talked about, really affect the course of all conditions. Next slide. The other thing I want to say too is as people age and they watch friends or loved ones pass away, they see their social circle shrink, their world becomes smaller, that becomes a stress too. Worrying about who's going to care for them. Things like that. So that's another factor to think about as people age. So what resources does Demas have for older adults with mental illness? So we do offer some programs. Next slide. So our nursing home diversion and transition program, we often just shorten that to diversion nurse program. But the program, we have 8 nurses and 3 case managers across the state that service the entire state. They are a great team. Their goal is to hopefully divert individuals from institutional care when possible, or help transition people out of institutions like nursing homes or state hospitals, and to ensure that they have a safe and appropriate transition plan. So they also are going to make sure that those nursing home placements for DEMIS clients are appropriate. This is a difficult one for our system, because what I see is that very often people will want to utilize nursing homes for mental health clients, but they want to do it for reasons other than medical, and that isn't a possibility. So for any person going into a nursing home who has Medicaid needs to pass a PASS-R review, and that's a pre-assessment screening and resident review. So the state of Connecticut has a company, Maximus, who will go out and do an assessment to make sure all Medicaid clients with a mental illness are appropriate to go to a nursing home. And that means that they have to meet level of care. So they have to have a medical need that needs constant attention, and they have to meet certain activities of daily living requirements to be appropriate for a nursing home. So I just want to reiterate. So the nurses very often will do assessments to see if someone is appropriate for a nursing home, if they meet level of care. If they are appropriate, then they're going to ensure that that person is getting, that the placement is appropriate and they're getting appropriate care within that nursing home. All right, I think I covered that, yes. So I mentioned the staff. They provide consultation to anybody, discharge staff, hospital staff, residential care homes, DEMIS programs, really anybody. They consult with probation, parole, Department of Correction. I just had a request this morning, so from probation. So they really are available to anybody in the system, and that includes the homeless services agencies. And they will provide consultation on medical issues, diabetes, education, mental health services. They can help link to services, or certainly give people ideas of where to go and what might be appropriate. They link people to medication-assisted therapy, residential care home placements. We have case managers that help with that as well. They are in constant contact with our Money Follows the Person and our mental health waiver staff to ensure that they're getting the care that they need. And really, they're there to help you determine the best community placement and how to help manage some of the medical issues that are going on with clients that they're assessing. So one of the big things that they do is this coordination and collaboration with the residential care homes. And what we're waiting, we just put in an amendment to our mental health waiver to be able to provide waiver services in residential care homes. We're not able to do that and haven't since the inception of the program. We're hoping that CMS will allow us to do that. But what the nurses have done is they've created a curriculum of trainings like Mental Health 101, professional boundaries, avoiding power struggles, de-escalation, things like that, bullying in a congregate setting. So what they've done is they've created these trainings, and they go out and provide those trainings at the residential care home for the residential care home staff, because staff in the residential care homes are not necessarily trained to deal with mental health clients or the issues that may arise with that population. So they've done a lot of outreach, a lot of work with the RCHs. They have great relationships with them, and often get people placed in residential care homes if it's the appropriate level of care. So that's work that we've done within our system, and it's really helped smooth the way for placements. And also we can go in if someone's struggling and help the RCH with ideas on how best to help that client so that they maintain that placement. All right. The mental health waiver. So again, if you have someone in the shelter or a program that you're working in and you're really struggling medically, or you're not sure, how to handle a referral for the diversion nurse program is on the DMIS website. You can go on under programs and services and send that in, and we're happy to consult and help in any way we can. The mental health waiver is a unique program in the way that not many states have a waiver program for people with mental illness. Connecticut is one of the few states. All states have 1915C Medicaid waivers, but ours is kind of unique in the country. So what it allows is people who have a severe and persistent mental illness that are at risk of institutionalization, whether it be a nursing home or a psychiatric hospital, to remain in the community living independently with wraparound services provided by Medicaid. And they do that at a lower cost to what it would be to live in a nursing home. And what we hope to do is keep people aging in place and keep people rooted in their community rather than in an institutional setting. So again, the cost of their waiver program has to be less than what it would be to house them in a nursing home. If it isn't, then they're not eligible for waiver services. It is a Medicaid program. It is operated by DMIS. We determine who gets assessed, who is enrolled on the waiver, but we work in conjunction with the Department of Social Services, who has the overarching administrative rights and the contacts with CMS. But DMIS is the one that kind of controls. We're unique along with DDS. So it is not a DMIS program per se. It is a waiver program. And so we have very different rules than DMIS funded programs. So we do not get, DMIS money. This is Medicaid funding. Advanced Behavioral Health in Middletown is our fiscal intermediary. They work very closely with us. They're wonderful partners, and they credential our providers. They do our quality assurance. We meet with them weekly. They train our recovery assistants. So they are our fiscal intermediary and really work in conjunction with us to run the waiver. Next slide. So it is recovery oriented. People have to agree to be in the program. It is a skill building program, not custodial. So sometimes clients want staff just to go in and clean their apartment. That's not what the program is about. We're there to teach them to do that. So hopefully we're making them more independent, where they might not even have to rely on the waiver after a while. And we do discharge people for not meeting our criteria, which is a good thing. So it's provided in a participant's home or in another community setting. People typically live in independent apartments. Congregate living is not allowed. People have to be able to come and go as they please. They have to be able to have a lease. They have to be able to be in a place that if they didn't get waiver services, they're not endangered of losing that housing placement. So we don't do services in group homes. We can in supported apartments though, or supported apartment programs. But typically people live in the community or an apartment. They can live with family. So we have provided care within a family home setting. And we're hoping that that will expand to residential care homes. And again, it's recovery oriented, skill building oriented. They have a person-centered plan, a recovery plan. It's developed with the individual, with a waiver clinician. They choose the services and they choose the provider that will provide that service for them. And we do have trained peers that provide peer support for people in the program as well. Next slide. So here's the eligibility. They have to have a serious mental illness. or they can have others like PTSD, for instance. And if the PTSD really leads to a chronic inability to really care for themselves, then that could qualify, as long as they meet these other criteria, which is that they're 22 years of age and older. They have to have Husky C. Now, if they don't have Husky C, but they have another form of Husky, we very often work with DSS to get that person eligible for Husky C. So as long as they can get Husky C, then they can be eligible, but they have to be on Husky C. They meet nursing home level of care, and as I mentioned, they have to voluntarily agree to be in the program. What we mean by nursing home level of care, they have to have 3 critical needs: bathing, dressing, feeding, meal prep, medication monitoring, toileting, or transferring. Or they can have 2 of those needs and 4 cognitive deficits. And that includes orientation, concentration, abstract reasoning, comprehension, planning, judgment, or attention. So that's what we use for our criteria. Next slide, please. So the services that we provide under the waiver, we have a community support program, which is case management, peer support, and supported employment. The support services are a recovery assistant, and the recovery assistants are really the backbone along with our community support program. They're the ones that can go in daily and work with clients hands-on, one-to-one, to do the skill building. We have transitional case management, so if someone goes back in to a facility but is going to come back out, we can provide those transitional case management services during that period of time. We have brief episode stabilization. We have some assisted livings that we can place people in, but assisted livings within our program, so not all assisted livings across the state would qualify for the waiver. We have tour services, so that includes heavy cleaning, bed bug cleaning, and then light tour service that we can do to help people maintain their apartments. And then we have specialized medical equipment we can get. We have non-medical transportation, though we really urge clients to find and really develop their own transportation network. We have a personal response, so it's the button that people can push in an emergency. We provide that. We can do adaptations to people's homes if need be, to make it more livable for them if they have physical disabilities that require that. Home delivered meals, and we have adult day programs. Next slide, please. With the mental health waiver, just to let people know, we do have a small wait list. It's probably about a month wait to get assessed, but I am always telling people, put in the referral, have it on, and we get to them as quickly as we can. We do have a new staff that started, so we're hoping that wait list will really cease to exist, by the beginning of August. But you, again, can find that referral form on the DMIS website under Programs and Services and Mental Health Waiver. So that's there for people's use. One of the other programs we have is the Senior Outreach and Engagement Program. So we just expanded this program in March. And so we now have 2 case managers in our 5 DMIS regions. So this covers the entire state. And the mission is to really do outreach to at-risk older adults and at-risk due to their behavioral health needs, or their substance use needs. Again, it's in all 5 DMIS regions, and our case managers will go out to residents, to nursing homes, to senior centers, community locations, shelters, wherever there's a need for an older adult. Excuse me. What they will do is they'll do an assessment, and then assist that older adult in whatever they need. So whether it's a mental health, navigating the mental health system, or the substance use system. And we know that navigating the mental health system isn't the easiest. They can provide linkages to treatment. They've provided a whole host of things, getting people to food banks, getting people signed up for various services, helping with social services applications, hooking people up with senior centers and older adult programming. Whatever the need is, the senior outreach engagement staff, if they can't do it, we'll link. So they're really a conduit. If somebody needs longer term care, the senior outreach and engagement staff will hook that person up with longer term treatment. So we don't have a set time to work with seniors. It could be a week, it could be 6 months. It's really whatever time is needed to really attend to the needs of that older adult at that moment. And hopefully what we're doing is, again, helping that older adult age in place and avoid any kind of institutional level of care if possible. Next slide. So here's the website, or some the DEMIS programs and services. This PowerPoint will be made available. Amber, you can send it out so that people certainly have this. But again, the DEMIS website will have information on the diversion program, senior outreach engagement, and the mental health waiver as well. If people have questions, they certainly can call me or send an email to me directly. I think, is my information on the next slide? No? Is that it? Oh, no. Oh, 211. So this is the crisis line now. People can get connected, and the National Suicide Hotline as well. And hopefully, the next slide. There I am. So feel free to reach out if you have any questions. I don't know if anybody has any questions now.
Great. Thank you so much, Erin. Yes, we'll open it up for questions. Feel free to unmute or put your questions in the chat if you would like.
And I can run us back to a specific slide if necessary, if people need to review.
Oh, thank you. So no questions, huh? Can I ask a question do people think they could or would utilize some of the services that I mentioned, either diversion, senior outreach? Would that be helpful at all in the work that you're doing currently?
Did you say, could people utilize it? I think I missed that one word. That was the only thing.
Yeah, I mean, do they think some of the programming might be helpful to them in the future?
Yes.
Because there's not I will say, with the older adults, I think people feel lost, right? They're like, what do we do? And it's like young adults, right? So I just didn't know if they think that those programs might be useful or helpful in any way, or were there cases in the past where you're like, oh gee, I wish I could have referred, or any difficulties that you might have had accessing services for older adults?
I'm seeing in the chat if people think it will be helpful.
Okay.
I would say, as Erin said, she has been doing this for, what did you say, 30 years, Erin, you've been with DEMIS?
Well, I've been with DEMIS 35, so
35 years.
I'd like to say I've seen it all.
Yes, we have been hearing so much within our sector about older adults. So I would encourage you all to take advantage of our time that we have with Erin. Ask her any questions about services, any type of scenarios that you may have, any difficulties about how to access services. But even if it's not necessarily a question, if it's something you want to try to work through and talk through with the group.
So I'm seeing something in the chat about what to do if someone, an older adult or disabled, is already homeless and there's no shelter beds. I don't have an answer for that. I don't know. What I would say is, and domestic violence services, what I would say is protective services for the elderly through DSS. If someone is a victim of domestic violence, you could certainly reach out to protective services for the elderly. And, you know, they will do an assessment. I don't know where someone would go if there's no shelter beds, because you certainly don't necessarily want to send them to an ER. But if they're in the middle of a medical crisis, then I would say, yes, send them to an ER. I don't know what to do if there's no shelter beds. If they're hooked up with Venus, we could look to try to get a respite bed, but I will tell you that very often the respite beds are full. But if they are connected to an LMHA, we should work with the LMHA to see if there's respite beds available for clients. If again, if they're, you know, in that Venus system. So I'm sorry, I don't have anything. Whereas because you can't turn. I don't know what to say. I mean, you don't want them on the street, and you don't necessarily want them in ERs because the ERs will just discharge them, you know, immediately. Okay, so the wait list for older adults. So the person that asked that question, wait list for what specifically? Because I think that is true across the board, the wait list, but I'm just for DNIS services or just services in general? It looks like Christine was the one that asked that. I don't know if she can.
I would say services in general. I'm at the Milford Senior Center and we have wait lists for everything. It doesn't matter what it is.
Okay. Cheapers. Technically, if there is
I'm sorry. I know that Christine just put something there where she says most elderly, in my experience, are afraid of shelters as well. I have a guy, he's probably somewhere in his 70s. Most likely he's suffering from dementia. I tried calling DSS to speak to his worker, and she kind of tried to brush me off, not giving me much information about what she has been working with. Asked me to call the conservator. I called the conservator. They sent me to the secretary. Won't give me much information either. He's alone here. He does have a brother, but the brother doesn't want to be responsible for him either. He wants to go back to Jamaica, but I'm not sure if he's going to have the proper services over there either, or if a family member wants to be responsible for him if he is in the early stages of dementia. The problem that I'm having is that, you know, we get these forms for them to fill out so that we could get information or support from other agencies. And then when you do call the other agencies, you know, to give them the proper services, they brush you off with, well, you know, I'm really not sure what you want to know. You know, I'm busy right now. You know, you need to call his conservator, and the conservator turns around and says, you need to call DSS and talk. Okay, so this is like a yo-yo thing. We need to understand, they need to understand that, you know, we're in a shelter and it's limited. So if a person come here with services already and have other case managers, and those case managers could work with us, the shelter people, and giving us the information that we need, they need to be cooperative and they need to take the time that we need in order to give them the proper services. But I'm getting brushed off. And this is a 78-year-old Jamaican man that lost it all during his COVID, and I have no support because they playing with me like I'm a yo-yo, and I don't appreciate that.
Yeah.
So it's like I have to start from the beginning. Does he have dementia? Does he not have dementia? Is he diagnosed? Is he not diagnosed? So it's like I have to start the process all over again because these other two agencies are not really giving me the information that I need in order to give him the proper services that he needs. And I don't think that that's fair.
I agree. What I would say is I do think the senior outreach and engagement program would be a good program for this gentleman, right? So they're at risk, they have nothing, and the case manager can come in and work with that person and work with the shelter staff and see what that person needs and do that immediate case management. So I would encourage you to go to, oh, go ahead. Oh, someone. So I would say go on to the DMIS website, get that referral, and send that in. It goes to Lorene Gomez. What area are you in? What of the state?
I'm in Hartford, but and that's the thing also that they came here. Elderly Protective Services came here and met with him. Also, the worker from DSS. I wasn't even aware of it until the meeting was over. So when I tried to meet with them, it was like, we gotta go. I should have been informed in the first place that they were going to be here so that I could express some concerns that I have so that I could advocate better for this man. So when they leave and I'm trying to set up an appointment with them, again, they brush me off. So I'm trying to set up another appointment with Elderly Protective Services as well with DSS, and they're giving me the runaround. This man has an appointment. He might be appointed a conservator on the 6th of July. And just to get him transportation, because he has a hard time remembering, I'm even having a hard time with that because the DSS is saying that they cannot provide the service, the transportation services. His conservator is saying that there is no money in the funds. I can't transport him because the agency doesn't allow me because of liability issue. So now I'm trying to get his brother, and his brother is upset. So where is the support that this man really needs in order to get from point A to point B, knowing that he has a hard time remembering things? So, you know, I hear a good talk when it comes down to the system, but when you go to the system and you express these concerns and you say, listen, he cannot go here by himself, and I can't even take him because of the liability issue, and plus we don't have a car. I can't send him on the bus because I don't even know if he's going to make it, you know, to this court place, and it's difficult to get to that place. It's like, are you going to work with him 100% and do what you need to do, or what do I have to do? There's times that I go out of my way and I don't even tell my agency. I just go and do it, but I can't lose my job either. You know, so it's like, are we really going to work together, or are we not? Because I can't send this person by himself. So I kind of had to put his brother against the wall and say, listen, your brother has a hard time remembering. You know, you really need to step up to the plate and help him out until someone or an agency decides to really work with him. You know, so, you know, I hear a good talk, but they're not walking the walk.
Yeah. Well, and unfortunately, I don't work for DSS. I share your frustration because, So Dorian Long is the supervisor at Protective Services for the Elderly. So that would be DORIAN.long@ct.gov. I would send an email to her as head to say, this is what happened, please assist me. And she's pretty responsive. So that's what I would tell you to do in regards to PSC.
Dorian.long?
Yes, DOR. Yeah, let me just hold on a second and I will double check on that. Let me see if, I don't know if I have, hopefully it'll show up. Yep, DORIAN.long@ct.gov.
Thank you.
You're very welcome. Yeah, she should hear that. Do you know what I mean? And that's what I would do. I would just go to her as the, you know, the supervisor. Okay, so they do not shelter house. That's right. So Protective Services does not house or shelter. They're not funded for those services. That is very true. But they can be of assistance, and certainly if it's a domestic violence situation. Oh, thank you for whoever. Thank you, Amber. I should have done that myself. So I was just there. I just want to be sure I answered. Oh, yeah, connecting people once they become homeless. So what program? So the Senior Outreach and Engagement can help connect people in need and can help connect people to programs. So if you're struggling with an older adult, feel free to send that referral in so that the Senior Outreach and Engagement person can come and assess and then get that person linked to needed services. So I would say that would be, you know, the program to start with. If it's a medical issue and you're really struggling with a medical issue, then I would say go to the diversion nurse who can come in and do an assessment and really help to see what's necessary. Oh, they don't help with DV. Oh, so they wouldn't even assess someone if they were a victim of domestic violence. Okay. Yeah, it's you know, DSS is going through a lot of transition, not to make excuses because it is frustrating. Anyway, oh, and somebody's asking how we reach them. I'm assuming they mean PSE. Oh. Yeah, I'm just, okay. Just looking at I'm not sure how, when Mary was saying, how do we reach them? If we're looking to reach Senior Outreach, again, go to the DEMIS website. The referral is on the DEMIS website. And we can go out to the shelters. And I'm not sure what Safe Connect. Yeah. Oh, BHK or somebody's just, oh, domestic violence. Okay. Yeah, I'm not sure, but we can't connect them to access or to assess needs. So it's hard. Yeah. So what I would say is if they're in your shelter and you know that they're there, Senior Outreach can come and begin that process of assessing them within the shelter. If they're on the street, that becomes a little harder for us. That is true. But if they're known to go to a certain location, we certainly can try to track them down. But it is a challenge if they don't have a cell phone and they're living on the street. That is a challenge. It would be a challenge for us because we're not a homeless program per se, but we certainly can work with the homeless population. But if they're in your shelter or in your facility, we can certainly make contact with them if you're willing to hold them, you know, for a period of time, so we can get there and see them. That would be helpful. We would want to work with you to see how best to meet your needs and their needs.
I don't work in
I don't know if that answers.
For a community health network. So I work for the company that administrates Husky. And part of my job is to help locate these people, to connect them with providers and services. And there's so many people that are not getting what they need because we cannot find them. And I'm trying to
I get it. Okay.
What is there for us to be able to help locate these people so we can connect them to the services they need. They're in need. We just have no way of reaching them.
Yeah, I'm sorry. I mean, I'm in the same boat. If we can't find a way to connect them, my programs, I mean, we do a lot, but if there's no way to find them or no way to connect with them, we do have homeless services within DEMIS, homeless outreach, and mobile outreach that certainly can, see people on the streets. I don't know how many still have homeless outreach. It's taken on many permutations over the last several years, but that's a challenge for us as well. I don't have any answers other than.
I'm almost wondering if there needs to be some kind of better partnership between like where I work and some of the shelters, because we're trying our hardest to find these people. We want to connect them. That is our job. That is our purpose. That is my entire team's purpose, is to connect them with these services. And I've been sitting here thinking for ages on like what would be a good way. And I'm almost wondering if some kind of partnership where we go to the shelters at set times when we know there's going to be people there or something, as like a little outreach program, might help get these people connected, not with just us and providers, but with you guys.
That makes sense.
Yeah, I would say connect with your CAN as well as organizations such as food pantries.
We do. We have food pantry outreaches. I go to the American Job Center myself twice a month. So we have those, but I know that there's so many people, they don't go to those things. They are maybe in and out of a shelter, but we can't really find them because they're in and out of shelters. So, there's a shortcoming somewhere where we are trying to, but we can't connect.
Got it. If you can, I can get your contact information and connect you to your local, like CAN and your street outreach team in your region.
Okay.
So that if you're connected with your street outreach team, you all can coordinate as far as who you're looking for.
Okay, that would actually be really good. Thank you.
Yeah.
But that makes sense, what you just suggested, having kind of an outpost and getting people. Yeah, I think that would be a great start.
Right. Anything else? And also I'm following the chat, and I didn't realize that Safe Connect did nothing for elderly. So I'm actually emailing before I forget the Connecticut Coalition Against Domestic Violence to ask for some resources about that for elderly when it comes to domestic violence. So as a follow-up for this training, I can provide some resources for you all on that area. But
great idea.
Any other questions that you all have?
Well, thank you guys very much. And again, you have my email. Feel free to contact me with questions. I'll try to point you in the right direction, when I can. So.
All right. Well, thank you so much, Erin. And as Erin said, we will have the slides available for you, and this has been recorded. So the slides will be available on our website. You can go to www.cceh.org. At the top, you can go to trainings and webinars, and you'll go to webinar library. And you'll be able to find the slides as well as the recording there. I can also email the group, those of you that are here, as I get additional information from the Connecticut Coalition Against Domestic Violence about the DV for elderly. But what I'm hearing in this group just overall is the need to have stronger partnerships and connections between the different services throughout the state for elderly. So that is something that I think Connecticut Coalition, I'm tired. I forgot where I work. CCEH can take on as far as something that we work on. But thank you all so much for being here. Erin, thank you so much for your time, and you all have a great day.